to Dr. Hollingworth. Thank you very much, Dr. Hollingworth, for being here. She is an assistant clinical professor, and she is our quality improvement officer here at Creighton. And I will turn it to you to speak on transitions of care. Thanks for being here.
Thank you. Thank you so much. And this is something really important for us to review, not only for hospital workflow, but also for you might get some questions on this for future exams for every specialty, family medicine, surgery. There's always going to be questions about quality and about transitions of care, patient safety. So our objectives today are to describe transitions of care, demonstrate the iPass tool. You may have heard of the iPass tool. And this is one of the things that ACGME likes us to use for our sign out. List measures of quality concerning transitions of care, and then describe some populations that may be negatively impacted. And I'm so glad that the residents are here today to help me out with this, such as the surgery residents like Dr. Galvis and Dr. Moreau, Kriegler.
Dr. Dixon is calling. We have a request for a SICU transfer. If you have a second, Dr. Hollingworth.
Oh, okay, I guess so. I'm in the middle of the presentation here about transitions of care, but if that's something you need to talk about. You said a SICU transfer?
Yes, let me have Dr. Dixon explain it. Hello, Dr. Dixon.
Medical Center?
Yes, this is Valleywise Medical Center.
Oh, that's right. You guys are Valleywise now. Right. I tried calling Banner and they said they didn't have these beds. Hey, I got a real problem here. Can you help me out?
Yeah, what's going on?
Yeah, who is this?
This is Dr. Galvis. I'm one of the SICU residents.
Oh, is that right? Is Dr. Matthews and Dr. Foster still around?
They're around here, yeah.
Oh, good. Can I talk to one of them?
They're actually unavailable. They're golfing right now.
Oh, you're just the resident?
I'm just the resident.
Is there an attending I can talk to?
Unfortunately not, Dr. Dixon. You just got me.
Okay, well, I got a patient needs a bed real bad.
Yeah, what's going on with them?
Got the bed?
We got a couple of beds. What's been going on with your patient?
Oh, great. So anyway, I'm out here in Timber 4, and we had a lady that had obstructing mass in her colon, and we just did a colectomy. She's not doing real well. I need to get her someplace for an intensive care unit because we can't handle her here. Any way I can send her to you?
Yeah. Could you tell me a little bit more about the patient?
Well, the PA did the HMP, and she got medicine clearance and everything from her internal medicine doctor. We just got done doing a total colectomy of this colostomy. She wasn't making a urine, so anesthesia gave her about 10 liters of fluid, and now we just can't get her off the bed and intubate her, and so she needs an ICU bed.
Huh. Okay. Well, we'll see what we can do. I need a little more detail about the patient. It just seems there might be a few things that we might be missing here.
Oh, she's 64 years old. What else do you need to know?
Kind of like what brought her in, kind of what happened in the OR, what post-op things you need done, things to look out for, kind of, the normal things.
Yeah, she had obstructing belly mass, and she really didn't have any pre-op workup except anesthesia and internal medicine started ahead of time, so she was okay for anesthesia. Her belly was really tender, so we took her. She had a mass in her sigmoid. We cut that out. I tried doing a hand sewn anastomosis, but it's been like 10 years since I've done that. Staplers didn't work real well, so and that took about 5 hours and got a lot of fluid. I might have backed the ureter. The anesthesia said she had lowering output, so they were giving her a lot of fluid, but maybe I backed the ureter. And then the leak test failed. So basically, I converted to an end colostomy. And I can't close the belly, and we can't get her off the bed. So I think she really needs to come to you guys. And she's not making any urine.
Got it. Okay, thank you. That was much more clear. Well, I appreciate it. Go ahead and send them on over, and then we'll go ahead and take care of them.
You want to know anything like the bed settings we have her on, or recent labs, or anything like that?
Yeah, sure.
Yeah, so we'll make sure we fax all that stuff to you and send copies along with her.
All right. Thank you, Dr. Dixon. I appreciate it.
Anything else I can do?
That's it for right now.
Is Dr. Alex Hollingsworth working there?
Oh, yeah, she's great.
I'm here, Dr. Dixon, but I wasn't that impressed with the sign out and the handoff.
Well, can I tell you a little bit more about it? She has a lot of stool spillage, and she's on 3 pressors right now. And we had to start the master transfusion protocol because the nose before wasn't sticky anymore. And so we don't have a Tagarosem here, but we started an MTP on her.
MTP. So usually what we do is try to use a standardized system to help with these kinds of transitions of care, especially coming from an outside facility, such as where you are out, like you said, in the boonies or Timbuktu, you said. And first of all, we like to use IPASS. And IPASS, so first, the I stands for illness severity. So the first thing you would want to have said was, this is either a stable patient, someone to watch, or someone who's unstable. So apparently your patient is on 3 pressors and you spilled a lot of stool and your anastomosis broke apart on you. So I would say this is an unstable patient. Do you agree?
I agree with you totally, Dr. Hollingsworth.
Dr. Galvis?
Yes, I completely agree.
Okay. And then the patient summary is the P, and that's where you say a summary about the patient, events leading up to the admission, hospital course, ongoing assessment, and plan. However, your patient basically came in, went to the OR right away, so they didn't really have a hospital course. They had an operating room course. But the ongoing assessment and plan is really the most important. And you kind of left out that the patient had massive transfusion protocol and was on 3 pressors until the very end. Oh, by the way, the patient's on 3 pressors. These are some things that you want to emphasize in this patient summary. And of course, in the next one. So in the patient summary, either Dr. Galvis or Dr. Dixon, if you can use IPASS method instead to summarize your patient, instead of the way Dr. Dixon had presented it.
Yeah, we can replay that. So what I'll do is I'll have Dr. Dixon give me a call again. Hello, Dr. Dixon. This is Dr. Galvis calling.
Dr. Galvis, how you doing?
Good. How are you?
Medical Center that I'm calling?
Yes, this is me. What's going on? I heard you have a patient to transfer.
I've got a 54-year-old lady who just got off the operating table after having a total colectomy or colostomy. She's unstable on 3 pressors on the ventilator, still septic, still requiring a lot of fluid resuscitation. We had a lot of blood loss, and we don't have Rotem or check here, but in the labs are having a hard time keeping up. We're running out of product, so we started a massive transfusion protocol on her. We don't have any capability of taking care of a patient this sick here, and I'd like to transfer to your facility. Is there anything else I can tell you?
Absolutely. Yeah. What initially brought the patient in? Kind of like the summary of everything that's happened.
She had an obstructing colon mass with a peritonitis on exam. We did a quick anesthesia clearance and internal medicine clearance. They said that we might start the surgery there because she was unstable and she probably needed to have a laparotomy. But once we got in there, it totally unraveled. We got the mass out. We had a staple misfunction and it leaked. And so I tried to do a hands-on anastomosis. That took a long time. And then that leaked. Then we mobilized the splenic flexure with some blood loss from the stinging, and we had to take the spleen out. And we started the massive transfusion protocol. We don't really have a way of monitoring anything here, so we gave her a lot of product, all the platelets and the FSP and the packed cells, but we're running out of product here, and we're having a hard time with the lab keeping up with that. So I had to convert her basically to an end colostomy and a Hartman and leave her belly open because she's got a ton of fluid. But she's also not making a lot of urine on top of the septic, so I might have bagged one of the ureters as well. She really needs to be in an intensive care environment, and we need a hospital. You need to get a transfer as quickly as possible. Anything else I can tell you about it? I can send you all the most recent labs that we have and her vent settings as well.
That is perfect. That's great. Anything to do on my end that you would recommend?
Well, I think as soon as she gets there, she probably needs to be re-explored once she's resuscitated.
Got it. Got it. Great. This seems to be a very clear sign out. We'll go ahead and take it from here.
Go ahead and place an aspirin and started on some. He gave us some prophylactic antibiotics, but we'll go ahead and continue antibiotics, and we'll keep the pressures on. Probably if you can send a life flight team that can manage her app there and blood products and her ventilator, that would be the best way to transfer her back in by helicopters as possible.
Great. So it sounds like we got an unstable patient and has some blood products to continue running and some intensive care monitoring. Any family members that we need to be aware of?
Yeah, they don't want me to transfer her, but I'm gonna get a two-physician transfer recommendation, so we can do that.
Great. Well, we'll take it from here. Thank you so much for the phone call. Appreciate it.
Galvis, thank you very much, and please send my regards to your attending, Dr. Hollingworth.
Will do. She'll be glad to hear from you.
That very good. They went through the patient summary and then the action list. They talked about re-exploring. They talked about that Dr. Dixon may have bagged the ureter, meaning may have injured the ureter during his colectomy, which could be pretty common during very inflammation around the colon. And he talked about labs that they needed to draw, maybe re-exploration, antibiotics, continued resuscitation, SICU, situational awareness. What's going on? What's the worst case scenario that can happen? So Dr. Galvis, what do you think the worst case scenario would be for this patient that you got out of that sign out?
I mean, this patient can code on us at any time. It seems that their volume down, not resuscitated properly, just overall pretty unstable.
Mm-hmm. Bleeding, maybe continued bleeding. It sounds like they're coagulopathic and he doesn't really have product there. And he tried to do MTP. So I'd be thinking about the worst case scenarios of what would happen: coding, bleeding, re-exploration, those things. That's like the worst case scenario contingency plan. And then the synthesis by the receiver, Dr. Galvis gave a very good summary of what he heard. What he heard may be different from what Dr. Dixon said, or maybe the same, but it's important for him to verbalize what he heard in case there are any errors in what he heard. And so that he could also restate what the action plan was. Well, okay, you want me to do this, this, and this. Is no, I want you to do this. So the restatement of your action plan is really important for us to go ahead with the correct plan so that there's no mistakes in our transition of care. Anything else, Dr. Galvis?
No, I think that kind of summarized everything. Just the, closing the loop, I think, is the most important thing. Like you said, repeating back what we've heard. Because I feel like with transfers, we hear a lot of information all at once. And kind of summarizing back is, closing the loop kind of aspect. And I like that part.
I noticed that in your sign out, you guys use iPass for your sign out at 6 o'clock.
Yeah, for the most part, we do. Us all kind of being together throughout the day, we kind of know about kind of what's going on, but always verbalizing what we know so that everyone's on the same page seems to really help. And this iPass, I think it's exactly how we kind of sign out. We start off with, they're stable, unstable, sick or not sick, and then kind of move into the overall. People tend to pay attention a little bit more to fine details when someone says, oh, this patient is sick. If I start out with not sick, it's not that we don't pay attention, but that, we're a little less concerned. When we have 50 to 60 patients on our list overnight.
So then I've noticed, I saw a skit the other day that Dr. Moreau had showed me, and there's different styles from different kinds of residents, maybe some giving more detail, some giving less detail. And it seems like that's definitely, this is a way you can kind of get the residents to stay into a certain algorithm pattern of handoff.
Yeah, absolutely. We can, might be hearing from one of my fellow medicine colleagues or emergency colleagues, if you want to kind of go over a little skit there.
Sure, that would be great.
All right.
Hey, this is Dr. Krigler. Are you ready for sign out?
Yeah, hey, this is Dr. Galvis. I'm calling, I got a patient, a consult for you if you've got a second.
Sure, let's talk about it.
Yeah, so I have a patient, it just got really bad facial swelling. I just want you to come take a look at it. We wanted an ENT consult. Think you come by?
Well, I mean, you're not really telling me much about the patient. What's the facial swelling due to, or when did it start?
Oh, I don't know. He said it started a couple days ago. It was from one of my colleagues gave it to me as sign out. I'm just kind of taking over care. He just has some facial swelling. Everything else looks fine. So if you guys can just come take a look, that'd be great and give us some recommendations.
How are the patient's vitals? Is he stable? Is he able to breathe?
Yeah, that's what I was told. The nurse said that he looked fine.
Have you even seen the patient?
I got sign out on it, so I haven't seen him yet, but my plan is to kind of see him when you guys come down.
Oh, so would it be okay if you could go see him and just let me know what's going on with the patient actually and see if we actually need ENT?
Oh, we got rounds right now, and I got a couple other patients to take a look at first. If you might just come and take a look. I gotta go. Okay. Let me know what your recommendations are.
All right.
Bye.
What are some pitfalls there in that sign out?
I mean, definitely clarity wasn't there. I don't know anything about the patient. I don't think Dr. Kriegler knows anything about them overall besides some facial swelling.
I think there's a really huge issue with not evaluating patients before calling for a consult. I think it's really important to make sure that you have all the imaging, all of your assessment ready to go before you actually make the consult so you can give them an educated sign out.
How would that affect the transition of care from wherever they are to admission or SICU or OR or?
I think a lot of things can get dropped or fall to the wayside because people haven't actually seen the patient. And so I feel like we're only going based off of documentation or hearsay. And so I think a lot of like significant issues can be dropped as they transition.
So maybe expediting OR, like if it's an necrotizing fasciitis case or something like that.
Yeah.
Okay.
Yeah, because if they know more information, they're able to convey it to us better, and then we can make necessary emergent plans if needed.
Okay. So how would you improve this transition of care using IPASS then?
I mean, I definitely sticking to the IPASS, kind of handoff structure. I think actually looking at the structure when, even signing out would be helpful. We can actually do another skit to show like the proper way.
Sure.
Hey, this is Dr. Krigler. Are you ready for sign out?
Yeah, hey, this is Dr. Galvez calling from surgery. I just wanted to get a consult from ENT if you have a second.
Oh, of course. Let's hear it.
Yeah, so this is a 64-year-old guy. He has a history of anoxic brain injury. Actually coming in with a couple of days of facial swelling. Unfortunately, this patient is nonverbal, kind of baseline GCS is about 6. He's on a tracheostomy, ventilator dependent and PEG dependent. Mother is with him, and overall he's a pretty stable patient. Kind of course, he came into the ED yesterday. We admitted him for observation. The swelling kind of gotten a little bit worse since then. We took an ultrasound to the face. We didn't see any drainable fluid collections. We just saw a bunch of inflammatory tissue. And so far his vitals have been stable. On exam, it's definitely swollen on the left side greater than right and extending down towards the neck. Otherwise, his labs have been, relatively normal. He's got a little bit of a white count to 11. Otherwise, his hemoglobins have been stable. Lactic acid is normal. His ABG also looks great. There's labs are kind of unremarkable. We did get a CT scan. The CT scan kind of agrees with our ultrasound, bedside ultrasound, which showed no drainable fluid collection, just a lot of phlegmon kind of in the area. As we have no etiology right now, we'd love to have you guys come take a look at him, just to see if you have any recommendations. As we're kind of at a loss here, what to do next. So far, we have him on IV fluids. We kept him NPO for you guys just in case. You want to take him to the OR. He's getting resuscitated. Has had great urine output, and there's kind of a low concern right now for any fasciitis or necrotizing soft tissue infections. So just let us know what you think. If there's any other questions I can answer, my team or myself will be here.
I don't even think I can think of one question. You really gave me an informative sign out. And thank you for preparing him for the OR, just in case we have to take him back. That was really helpful. We'll take a look at him for sure and let you know what we think.
Thanks so much.
So if you, and then you would use the synthesis as well, Dr. Krigler, for like, okay, so it sounds like you have a 26-year-old male who has a noxic brain injury with edema of the left face with no drainable collection. Vitals are stable, and go from there. The thing I have to do tonight is to follow up on cultures or CT scan or whatever it was that you needed to do. That would be a good synthesis. So if you give back your synthesis, that you're basically informing Dr. Galvis that you had heard everything he said. So for a PEDS example, anything else, Dr. Galvis? Dr. Krigler?
Sorry, I accidentally cut her off by muting her. So she was going into that.
Oh, she was? You cut her off?
Yeah, that was my fault. I apologize.
Okay. Okay. So as far as a PEDS example, because there are different residents on this call here, and so we have a PEDS resident, and the resident says, okay, this is our sickest patient, and he is full code. It's a 4-year-old boy with a history of 26-week gestation, admitted for hypoxia, respiratory distress, secondary to left lower lobe pneumonia. He presents with a cough, high fevers, 2 days before admission, and he came to the ER with worsening respiratory distress. He's found to have a sodium of 130, likely secondary to volume depletion or SIADH. He received some IV fluid bolus, started on oxygen at 2.5 liters, and he's on ceftriaxone. My patient summary: the action list, please look at him at about midnight, make sure his vitals are unchanged and his oxygen sats are stable. Check to determine his blood cultures are positive tonight. And I would probably also say, see if his respiratory distress is getting worse. Because the situation awareness part, if respiratory distress is worse, get a chest x-ray to determine if he's developing effusion. I would be like, well, maybe he also needs to be intubated. That's another thing that I'd be worst case scenario planning. So then the receiver says, okay, AJ is a 4-year-old boy who's a ex-preemie who's admitted with hypoxia, respiratory distress, secondary to left lower lobe pneumonia. He's on ceftriaxone, fluids, and oxygen. You want me to check on him at midnight. So we want to make sure that you not only have an action plan, but you want to know who you're telling to do it. So Dr. Dixon should have told Dr. Galvis, I need you to do this, and I need the SICU resident at night to do this. And when we assign specific people, it's more likely to get done. And also the documentation. We don't want to just check off a box that we actually saw the patient. We want to actually make sure we're actually taking care of the patient. We're not just there to check off the box. If the respiratory distress worsens, I will repeat a chest x-ray, look for an effusion. And I would also think that I would determine if the patient needs to be intubated. So there's a PEDS example. Any other examples? Radiology, family medicine, internal medicine, EM. Anybody else have some examples of some frustrating handoffs that happen constantly? So transition of care, well, I just want to talk briefly about transition of care and what it is. You could be asked questions on your board exams, on some of you may have step 3, some of you may have board exams coming up. Most of you have done some in-service exams, but these are things that even like for certification in surgery and qualifying and certifying exam will still have questions on transition of care. So the transition of care is a movement of a patient from one setting to another. It could be the hospital to a rehab, or ambulatory primary care to a specialty care, long-term care facilities like an LTAC, home health, even rehab facility. For us, it's mostly ICU to floor, floor to ICU, could be recovery room to floor ICU. A lot of issues happen there. I recently had the PACU call me about a CT scan, and they told me they needed an order in the chart for a CT scan, and I needed to put in the order for the CT scan for Dr. Feiserfan. Well, it turns out he didn't want the CT scan post-operative like he usually does. He wanted it the next day. So there was definitely miscommunication in that transition of care. The emergency room to the floor and the ICU is somewhere where there's a lot of issues. One I had recently was an EKG was ordered, and we didn't know about it, and there were EKG changes in a trauma COVID patient. So that was something that the communication we're working on for new orders that happen in that transition of care. The ED to OR is another one. Usually for trauma, it's very quick, but for other cases like necrotizing fasciitis and things like that, where the patient's sitting in the emergency room, we can have some issues with transitions of care with patients being watched, or vitals, or with antibiotics, things like that. When you do have transitions of care, it increases the risk for lots of errors, such as miscommunication, medication errors, ordering certain tests like the CAT scan. Basically, these are things that we can improve on in the hospital, and I'll talk about quality measures next. Hospital discharge is really complicated, as you know, when you're trying to discharge these patients, especially the ones who have been in the hospital for months. Those are the patients that are especially at risk. Patients that have a lot of medications to prescribe and continue, patients that are going to a rehab or going to an LTAC, they're particularly vulnerable to having adverse events. So what are some discharge issues you have encountered? I can say for me, I've seen some discharge issues could be the patient came in for a major trauma, and we're taking care of them. They had an X-lab, they got all kinds of ORIFs, but they may have had like a kidney mass or a kidney cyst or an ovarian cyst or something incidental, an adrenal mass, incidentaloma, something that they need to go follow, pulmonary nodule, things they need to follow up with their PCPs, follow up with a CT scan in a few months. Those are some things that can get dropped very easily in the transition of care, especially if they're going to rehab and then they go home. Those things might get missed. Or medication errors, such as you discharge the patient on a beta blocker, they're already taking a beta blocker at home. So then they don't understand, and they take both beta blockers, and then they get readmitted. They're bradycardic and hypotensive. So those are some things that are very common in transition of care, and those are the biggest issues that we have. If anyone else have discharge issues that they've encountered?
I think the biggest thing is communication with the patient about instructions. I think especially when they're in the hospital and we tell them 1,000 things, having them remember the few things that they need to do can get complicated. So I think writing stuff down and giving them good written DC instructions and easy to read and is critical for the patient, because I think that lowers their, I don't want to say bounce back, but their return to the ED or to wherever with issues.
Yeah, so like for trauma patients, surgery patients, like wound care instructions. One of the QI projects that a couple of the residents are working on deals with explicit wound care instructions, where the patient can understand exactly how to dress their wound and exactly what they need and the supplies. That will decrease the amount of bounce backs, and like you said, to the ED. And it's interesting you say that, because that's actually, those are quality measures, Justin, of transition of care. So when we're talking about quality measures, we want to know, well, how good is Valleywise at transition of care? Well, we know by looking surgery readmission rates, ED visit readmission rates. So we like to see the patients when they come into the ED to prevent any readmission for really, if they don't really need to be admitted. So for one of the big quality measures has to do with heart failure admits. And like Dr. Galvez said, having a written complete discharge instructions is very important. And that's one of the things that decreases the patient returning back with a complication and getting readmitted. Not only that, but like Dr. Galvez said, communication about the discharge information. I mean, you can just give them the information and they'll only get about maybe 15 to 20% of what you're saying, because they just want to get out maybe of the hospital. But if you communicate with them and try to sit down with them so they really understand and show them on the paper what's the discharge instructions are, then you can really decrease your 30-day risk readmission rate. So it actually is true about what you said, bounce backs. So getting that discharge summary, getting the communication face-to-face is really, really important. Most discharges are the diagnosis is heart failure. And this is not something that all of us have to deal with, all the residents, but this is something that CMS looks at as far as the amount of money, because it costs billions of dollars per year, 17 billion per 1 million patients a year. But since 2005, we've gotten better, because we have gotten better at those printed out discharge summaries. And not only printing out discharge summaries, but printing out discharge summaries that they understand and communicating with them, going through them. So it went from 57% to 94% in writing out a discharge summary. Significant. There are disparities still with within transitions of care, and all different transitions of care, not just discharge, but also transfer to home health or transfer to home, any facilities. It's with the American Indian and American Native population per CMS. So this is just visual of the kind of written discharge instructions for CHF and what has happened as far as increasing the amount of discharge summaries given. However, as you can see with the blue line here, there's still a huge disparity with American Indians and American Natives per the CMS language. So that's our population, right? So we have a lot of this population in at Valleywise, and this is our mission to take care of these populations. So it'd be interesting to see if we actually have a better rate of written discharges and a better rate of communication with these populations. That would be something interesting for someone to look at as far as quality improvement project, if you don't have one. So the here's a chart talking about the communication, like Dr. Galvez had talked about, whether they agreed, disagreed, or strongly disagreed about understanding their health management after discharge or transition. So again, American Natives and American Indians are the ones who have the highest disparity of understanding their transition and their discharge instructions. Why is this important? Is because it will reduce the emergency room visits, the emergency department visits. This has been shown. CMS reduces rehospitalization. So if I have a patient with CHF and I don't give them the proper refills and the proper instructions about their medications and sodium and fluid restriction, then they may have issues with that and then come back very quickly. So if you can have a simple conversation with them before that, those kinds of things prevent rehospitalization. Also with maybe gallbladder, if you're taking out someone's gallbladder and they might have some, maybe they'll have some side effects, diarrhea, something like that when they're eating. If you explain these things ahead of time and then they have it in their head, what may happen, it might reduce a visit, because we get a lot of post-operative consults in the ED from people who weren't sure what to expect after their transition of care from the PACU to home or even in the hospital. So the other importance is that it'll improve health outcomes in general. If people are aware of how to manage their CHF at home or how to manage and prevent any further issues, then this will improve outcomes and decrease expenses overall. Readmission rate is something that has declined since 2010. It is a measure of quality. So we're using it not only for CHF and other things, we're using it for trauma, for geriatric trauma, readmission rate in general we follow. And the basis for this would be preventing complications. If you can try to prevent complication, you're preventing readmission. You want to teach patients at discharge their instructions, what they need, or before they go to a rehab, what to expect, what they need to have done over there. Explain it to them as well, not only in the discharge instructions to the LTAC or rehab. You want to also make sure the patient's understanding what medications they will be continuing at their rehab, and then what might happen if they go home. Are you going to continue their steroids in the rehab, and then they probably would be done with that, and then they won't be continuing the steroids at home? That's like an important thing to mention to the patient. We want to make sure they make these smooth transitions from their from the hospital to the next transition. And this might involve case management, social workers, and also they have transitional coaches that will come out to people's homes and check on patients in that transition, and especially with trauma and for surgery. Anything, and so I'm pretty much done with this, but I wanted to know if there was anything else you wanted to discuss with transitions of care, because we do have a lot of things happening in the hospital right now, and it's very busy, and there are less beds available, less staff available, and might be an opportunity if you wanted to discuss anything or any questions. Linnea, anything from you, Dr. Moreau?
Nothing. That was a great presentation. Want to thank all the skip was doing the skip. They were awesome. But no, I just think, yeah, reiterating how important, how important this is for, especially, given all our sign outs and sign ins to each other. There's so many opportunities to, miss key details and affect patient care. So I think being really cognizant and having a refresher of like how to properly sign out and what the, is so important for us. And then one other thing that during the presentation I thought is, which I like to do too, is like, when you're getting sign out from someone, I think it's always important where from like, especially the private or the day team, if they say, okay, well, if this happens, we'd like you to do this. So almost like forward thinking about possible things that could be happening over the night and how they want you to proceed. So the worst thing is, if you're on night and something happens and you're like, okay, well, we could go this route or this route. I wonder what the main team wants. So always like, even as the sign out team, knowing, kind of anticipating some of the things that they may get called on and telling them how to proceed, that really helps as well. I don't know, that was a little tidbit I had. That's it.
Yeah, I mean, even the attendings, when we sign out to each other, say, if this happens, give more fluid, or do this, because you're not there all day in the ICU, or you're not there all day on the floor. You're coming in at night for night, and you don't know exactly, what's working for the patient, what's not working for the patient. And then that's the most important thing. I think the most important thing is exactly what you hit on, is if things really go bad or something, what to expect, what should be the plan.
Right. And then, yeah, and then it's just so, because then it's like the nighttime is not like, the last thing you want is like daytime come in and the nighttime has done something different, like another option, but a different kind of track. And then you're almost reinventing the wheel every shift, which is like a wasted, like inefficiency of care. So yeah, if it's like, I feel like that's just a way to keep the team almost even more cohesive night, daytime. But
Okay. Well, great. Then I will give you back 15 minutes of your time so you can go to one of the food trucks or go to one of the areas to get some food. And thank you so much to the residents for participating, Dr. Dixon. And that's it.